Good afternoon. I am Evangelina Capobianco, and I'm glad to share with you this talk. So I want to thank to the organizers for inviting me to share our results. The title of the talk is Programming of Metabolic Pathologies Related to Maternal Diabetes. Well, for the ones who are not familiarized with diabetes, I told you that there are several types of diabetes, and type 1 diabetes is a chronic pathology that occurs when the pancreas does not produce enough insulin. Type 2 of diabetes occurs when the organism cannot efficiently utilize the insulin that it produces, perhaps because of alterations in insulin receptor, or sometimes with alterations in intracellular signaling of insulin. So this leads to an increase in the levels of glycemia in blood. So and leads to the damage to several organs and systems. Another type of diabetes is gestational diabetes mellitus that occurs when insulin secretion does not compensate the physiologic insulin resistance of pregnancy. And it is important because it has a high prevalence that runs 14% all around the world. Several environmental factors lead to epigenetic changes that combines with genetic factors and increase the risk of GDM. In women who develop GDM have a high risk of developing diseases later in life, as well as the offspring of women who develop GDM are prone for the are candidates to develop type 2 diabetes and obesity in their future life. So this is a cycle that increases the next generation prevalence of GDM and type 2 diabetes. And it is very difficult to stop the increase in this prevalence. In our laboratory, we have only studied diabetes in pregnancy in several models of diabetes in rats, but also we have studies in patients from the hospital. The results that today I'm going to present you came from a model of mild diabetes that is induced by an injection with streptozotocin to 2-day-old female neonates. In adulthood, these female rats have mild hyperglycemia, and when we mated them with control males, we have studied the embryo, the fetus, and the placenta that is exposed to this adverse environment of a mother with diabetes. And we observed several inflammatory and lipid disorders related with increases in resorption and implantation rates, and also with alterations in embryo, fetal, and placental development. Today, I am going to focalize in the study of the offspring of these mild diabetic rats in different stages of postnatal development, such as lactancy, youth, and adulthood. Our first results showed that from the first days of life, we found that the offspring of diabetic rats have an increase in the levels of triglycerides from day 14 of age. and they still are observed at 5 months of age. However, the increase in glucose levels appear at the age of 5 months in the offspring of diabetic rats. So we observed that the alterations in lipid metabolism are evident in the offspring of mild diabetic rats previous to alterations in glucose metabolism. Another conclusion of these results is that from a mother with mild diabetes characterized for high glucose and low insulin levels leads to the programming of type 2 diabetes in their offspring with high levels of glucose and also with increase in insulin. Although at 2 days of age, the offspring of diabetic rats seems to be similar to controls, we found that in the heart of this 2-day-old offspring, in the heart, we observed an increase in the levels of nitrotyrosine. Nitrotyrosine is a marker of peroxynitrite-induced damage that we can observe in the atrium and ventricle of the offspring of diabetic rats. We also observed increases in the levels of matrix metalloproteinase 9 as a marker of inflammation, also in the atrium and ventricle from the hearts of the offspring of diabetic rats. So then we continue our studies thinking that if the offspring of mild diabetic rats have increases in the levels of glucose at the age of 5 months, we wonder what happened if we mated a female offspring at the age of 3 months when they were normoglycemic. So we mated this female offspring with control males, and we observed that by the end of the gestation, these rats developed gestational diabetes mellitus. So we studied the F2 fetuses and placentas at day 21 of gestation. And so this model of GDM, gestational diabetes mellitus, was characterized by increases not only in glycemia, obviously, but also increases in insulinemia, triglycerides, and cholesterol in plasma. When we studied the fetuses, we observed increases in fetal glycemia, fetal insulinemia, and also fetal weight. This is very important since fetal overgrowth is an alteration related to intrauterine programming of diabetes. And one of the most important mechanisms that regulate fetal growth is the mTORC pathways. mTORC is the mechanistic target of rapamycin that plays a central role in placental nutrient sensing and fetal growth. There are 2 complexes, mTORC1 and mTORC2, that leads to the phosphorylation of several proteins, such as 4BP1 and AC kinase 1, or mTORC1, and the phosphorylation of AKT, HG kinase 1, and PKC alpha by mTORC2, leading to the regulation of cell growth and proliferation. So in collaboration with the laboratory of Thomas Johnson and Teresa Powell at the University of Colorado, we studied the mTORC pathways in the placentas of GDM rats, and we observed a decrease in total levels of 4BP1 and normal levels of 4BP1 phosphorylated or EBP1, concluding that mTORC1 pathway is upregulated in placentas from GDM rats. We also studied the mTORC2 pathway in these placentas, and we observed a decrease in the total levels of PKC alpha at normal levels of phospho-PKC alpha, and together with the increase in the phosphorylation of HGKNAS1, led us to conclude that in these placenta, in those placentas, there was an upregulation of the mTORC2 pathway. In our lab, we have deeply studied peroxisome proliferator activated receptors, and there are 3 isotypes of PPARs, PPAR alpha, PPAR delta, and PPAR gamma, and they are activated by different types of ligands, such as eicosanoids, long-chain polyunsaturated fatty acids, and monounsaturated fatty acids, and they heterodimerize with the retinoic X receptor and binds to peroxisome proliferator responsive elements in the DNA. When they bind with PPAR agonists, release the binding of co-repressor molecules, leading to the transcription of several enzymes that regulate different processes such as cellular differentiation, metabolic homeostasis, and anti-inflammatory and antioxidant process. In our laboratory, we have found that in maternal diabetes, PPAR gene and protein expression and PPAR function are altered from very early stages in development, since organogenic phase in the fetus and the placenta development. So we studied the levels of PPARs, and we found that in placentas from GDM rats, the expression of PPAR alpha and PPAR gamma were reduced. Together with the results, we found an increase in the levels of lipoperoxidation and nitric oxide production, as well as increases in nitrotyrosine. These increases are related with the low levels of PPARs found, since they are very important regulators of inflammation and antioxidant pathway. Then we study the liver of the fetuses from control and CDM rats. And in this case, we studied them separately, males and females. And we found that in the liver of both male and females, in this slide, we are showing the same in fetuses from male and female fetuses. And we found an increase in the levels of nitric oxide production, an increase in lipoperoxidation, and also an increase in markers of inflammation, such as CTGF and matrix metalloproteinase 2. Then we studied the levels of lipids in the livers from male and female fetuses, and we observed an increase in triglycerides and cholesterol in the liver of male fetuses, but a decrease in the levels of these lipids evaluated: triglycerides, cholesterol, phospholipids, and free fatty acids. So we have observed sex-dependent differences in the livers from two genders of sex. So then we study the expression of PPARs, and we observed that in male fetuses, the protein expression of PPAR gamma was increased, and also the expression of protein expression of PPAR delta. When we studied female fetuses, we observed that PPAR delta was also increased. So the observed increases in PPAR gamma and PPAR delta in the liver of male and female fetuses prompt us to study the expression of microRNAs that target and negatively regulate the expression of those PPARs. So we studied the expression of MIR130 that targets PPAR gamma, and the expression of MIR9 and MIR122 that targets PPAR delta. And we observed that in male fetuses, the expression of MIR130 was decreased, the expression of MIR9 was decreased in the liver of female fetuses, and the expression of MIR122 was decreased in the liver of male fetus. We also measured the levels of MIR122 both in plasma of male fetuses and in plasma of the mother. And we found that in both cases, the expression of MIR122 was decreased. Then we studied the expression of lipid synthesis enzymes, and we found that in male fetuses, the expression of FAST and AC1 was increased, but not in the liver of female fetuses. Remember that in the liver of male fetuses, levels of lipids were increased. And in the liver of female fetuses, we found a reduced content in the levels of lipids that could be related to this increase observed in the expression of lipid oxidation enzymes observed only in the liver of female fetuses. So in summary of this part, we found that maternal diabetes leads to the development of gestational diabetes in the offspring at the age of 3 months old, with metabolic disorders in plasma and liver too. When we studied the F2 fetuses, we observed an increase in fetal growth, glycemia, and insulinemia, an increased expression of PPAR gamma, probably related to the decrease in the expression of MIR130. We also observed an increase in the lipid content in liver from males, probably related to increases in lipid synthesis enzymes in the expression of these enzymes. We also observed an increase in PPAR delta, probably related to a decrease in the levels of MIR122 that could be leading to the reduced content in the liver from females and related to the increase in the expression of lipid oxidation enzymes. When we studied the placenta, we observed an increase in the pathways of mTOR1 and mTOR2 that could be related with the increase in fetal growth. And we also observed decreases in the expression of PPAR gamma and PPAR alpha that are related with this increase in the pro-oxidant and pro-inflammatory damage observed. So then we wanted to study the offspring of 5 months of age that developed type 2 diabetes. And we studied the plasma, the heart, and the pancreas of the adult offspring. We found that both in male and female offspring, the increase in glucose was accompanied by increases in insulin levels and triglycerides. And this work was made in males, only males, and we found that in the heart of male offspring, there is an increase in the activity of cardiac creatinine kinase enzyme, MB, and cardiac lactate deshydrogenase. We also observed an increase in the activity of matrix metalloproteinase 2 in the heart of the male offspring, related to increases in pro-inflammatory state. We know that MMP2, the matrix metalloproteinase 2 is able to cleave the carboxy terminal of connexin 43, and connexin 43 is the main component of the gap junctions and hemi channels in myocytes. So we measured the levels of this protein, and we found that they are reduced in the heart of male offspring that develop type 2 diabetes. Then we study the pro-oxidant and pro-inflammatory damage in males and females, and we found an increase in lipoperoxidation, and an increase in nitric oxide production, as well as alterations in lipid levels. We found an increase in triglycerides in the heart of males, and increases in phospholipids and cholesterol in the heart of females. Finally, in collaboration with Dr. Alani and people of her lab at the University of Western Ontario in Canada, we studied the pancreas of the offspring of mild diabetic rats, and we observed a reduction in the percentage of islet in total pancreas, but only in males. The rest of the work continued on the study of males, and we observed a decrease in the expression of PPAR gamma and PPAR delta in the pancreas of male offspring. We also studied the number of different sizes of islets, and we found that there was a decrease in the number of small islets, leading to a reduction in the number of total islets in male offspring. Although most studies have concentrated on maternal environment, in the last decade, has become evident that paternal nutrition, obesity, type 2 diabetes, and preconceptional environmental exposures also affect the developing male germ cells, conducting to the conditioning the offspring's future health. In this way, Bohat paradigm was introduced to stress the needs for more research on the role of the father in the transmission of alterations to their offspring. And some epidemiological studies and other experiments in animal models have concluded that the sperm epigenome functions as a vector to transfer preconceptional environment messages from paternal environment to offspring. And the mechanism of transmission that are from epigenetic nature are changes to sperm DNA methylation, sperm small non-coding RNA content, and global acetylation levels. On the other hand, we know that placenta is one of the main determinants of fetal growth and a key player of fetal programming. This fact, together with the fact that the paternal genome has a major influence on placental development, open a new line in our laboratory, focusing on the study of the placenta in the paternal programming. So to test this, we studied the F1 male offspring that developed type 2 diabetes at the age 5 months of age. We mated these males with healthy female rats, and we studied the fetus and the placenta on day 21 of gestation. These are the results that I showed you before about the metabolism in the father. And when we study when we made metabolic determinations in fetal plasma, we observed that glycemia was normal in the fetuses, but there was an increase in triglyceridemia and cholesterol. We also observed an increase in fetal weight, but placental weight was similar in both groups. Then we study the levels of lipids in placentas from males and from female fetuses, and we observe an increase in triglycerides, cholesterol, and free fatty acids only in placentas from male fetuses. Placentas from female fetuses, the levels of lipids were similar to control. Then we study the expression of PPAR alpha and its coactivator PGC1 alpha, and we found that their expression was increased in the placenta of male fetuses. However, the levels of PPAR gamma are similar in both groups, and we didn't find differences in placentas from female fetuses. Then we study the expression of lipid oxidation enzymes, and we observed that in placentas, only in placentas from male fetuses, there was an increase in the expression of ACO. And the study of the expression of lipid synthesis enzymes showed that there were no differences in the expression of these enzymes evaluated in the placentas of males and female fetus. Finally, we studied the expression of lipid transport enzymes, and we observed that only in placentas from male fetuses, there was an increase in the expression of fatty acid transport protein 1, LipG, LPL, and the fatty acid transporter CD36. But no differences were found in the placentas from female fetus. So in summary, we say that paternal diabetes programs fetal overgrowth and alterations in the fetal placental lipid metabolism. The intergenerational transmission of these metabolic alterations may lead to adverse consequences to the adult offspring. So we ask for interventions that could be useful, and there are some works that have tested some interventions such as exercise and diet prior conception that improve circulating metabolic parameters and reduce the effect of obesity-induced programming of impaired metabolic health in next generation. And thinking on diabetes, we know that in maternal diabetes, there is a disbalance between metabolic substrates. There is an increase in metabolic substrates and a deficiency in essential fatty acids that lead us to test several treatments. Some of them with antioxidants, but others with diet supplemented with olive oil, rich in monounsaturated fatty acids, and diet supplemented with safflower oil and chia oil, rich in polyunsaturated fatty acids. Remember that MUFAs and PUFAs are agonists of PPAR. So we test these diets in the mother during the gestation of the mild diabetic rats, with very beneficial and hopeful results not only during the fetal development, but also in the different stages of the offspring after birth. So we can conclude that maternal diabetes leads to the development of gestational diabetes mellitus in their female offspring of 3 months of age, and maternal diabetes also programs type 2 diabetes in males and female offspring of 5 months of age. And when we study the next generation, we have a lot of works on the study of GDM, where we observed an increase in fetal growth. We evidence pro-oxidant and pro-inflammatory damage in the fetus and placenta, and also lipid alterations in the placenta and fetal liver. Our first results in the offspring of type 2 diabetic males showed that the father leads to fetal overgrowth, and we can observe lipid alterations in fetal plasma and in the placenta. So the intergenerational transmission of these metabolic alterations may lead to adverse consequences to the adult offspring, supporting the transmission of them to the subsequent generations, increasing even more the prevalence of diabetes. And our proposal is that maternal dietary treatments with PPARs agonists could be a strategy to ameliorate the fast increase in the prevalence of diabetes. Well, this is the people of our lab, directed by Dr. Alisa Hauerbaum. We work together with Dr. Romina Iga, and most of the results I showed were performed by Diana Fornes when she was doing her PhD. And these are the other people of our lab, Dalmiro Gomez-Ribot, Cynthia Gatti, Sabrina Roberti, and Laura Leonardi. And we work in collaboration with Dr. Veronica White and Florencia Heineke. So thank you for your attention.
Wonderful. Thank you so much for that presentation, Dr. Capobianco. I'll open it to the group. If anybody has questions, please use the Q&A. But while we're waiting, I can kick it off. I have to say, the data are so striking in the paternal programming model. And I'm wondering if you have any ideas about the sex-specific differences that you're seeing in the F2 offspring, because that's pretty profound.
Yes, we didn't study them deeply, but we have evidence of our other model of, for example, gestational diabetes, where we found a lot of differences between sex. And we know that some sex hormone receptors or the levels of sex hormones are involved in this this different regulation of the metabolism in the females and males. Here we don't know, but we noticed that males are more affected than females, but we still don't know why.
Great, thank you. We have a few questions coming in. So the first one, is there an intervention window in the offspring in early postnatal life rather than in the mother?
If the window is open in the mother, can you repeat me the question?
Yes. So it's basically asking, is the intervention window for the offspring limited to the mother, or do you think there is possibility for intervention in the offspring?
Okay. Yes, and yes, we think that surely we have several studies where we interview the mothers the very early, sometimes for very short periods of time at the beginning of gestation, and we observe that there are beneficial effects later in life during during the development of fetuses, but also then in the offspring. So, but our best results are shown when the interventions are all over the pregnancy of the F0 mother. So, well, I don't know if this answer your question.
Yes, absolutely. And there's another question about the litter sizes in the maternal and paternal diabetes models.
Uh-huh. Okay, the litter size are the same. Did not differ between the control and diabetic.
There any other questions? Give people another minute or two. All right, here we have another. I wonder whether you have information regarding the rate of viability and diabetes in pregnancy in female rats that were separated from the male rats when they were first injected with STZ, compared with maintaining the entire litter together for maternal care.
The question is if are there differences in the rate of
viability in diabetes.
I think that I don't understand the question, but if the question is if diabetes have different effects in the fetuses, in the female and male fetuses in the F0, is this the question?
So I think what the question is that when the female rats were separated from the males when they were first injected.
Yes. No, this model starts with the injection of streptozotocin at 2 days of age, and we adjust the number of newborns to the mother to 10. So, for example, if we injected six female rats, we maintain 4 more males, but then we didn't use the males of this the brothers of these females injected. I don't know if I'm answering the question, because we study the female rats injected by with streptozotocin. We maintain the same size of the siblings. Okay, so the mother has not to be have different amount, a different number of pups during lactancy.
Another question. What is the biological or clinical relevance of your findings? What does it mean for us going forward in our fight against non-communicable diseases such as metabolic dysfunction?
Okay, we have some studies, with some translational studies with women at the hospital Pirobano in Buenos Aires, Argentina, and we have we have started with interventions with diets enriched in monounsaturated fatty acids. With it is a diet with olive oil, extra virgin olive oil. This is a normal lipidemic diet, so it is useful, or you can use this kind of diet to people who has diabetes and people who not. But in diabetes, we observe very good, very beneficial effects on placentas and also in the cord blood. So I think that improving or targeting the expression and the functioning of PPARs that regulates lipid metabolism with these diets have very hopeful results.
Wonderful. Thank you so much. And
You're welcome.
say if there aren't any other questions, then I would like to say again, thank you. Thank you, Dr. Capobianco, for sharing this exciting work with us. This was wonderful. Our next webinar will be Wednesday, June 1st, and we are looking forward to seeing everybody there. And in the meantime, have a wonderful rest of your day, evening, morning, and
Thank you. Thank you
and
for inviting me to share this talk.